Welcome to Breakdown. This is our new season of the ER and hospital journey. Welcome to episode 2. Today, we are going to break down the whole crazy, confusing, and pretty stressful journey through a medical emergency, all the way from that first visit to the ER to the final bill that lands in your mailbox. You know, a medical emergency can happen to anyone at any time. It's that one moment you just never see coming that turns your whole world upside down. One minute, everything's normal, and the next, you're thrown into a situation you are completely unprepared for. So let's really get into it. We're going to walk through this entire journey piece by piece and hopefully pull back the curtain on what really goes on. We'll look at it from your perspective as the patient, and we'll also see it through the eyes of the first responders and hospital staff who are right there on the front lines. Okay, so our story starts with something first responders see constantly. A patient takes a really bad fall and ends up with a tibial fracture. That's a break in the shin bone. And listen, this is way more than just a simple broken bone. This injury starts a clock, and it is ticking. And this is a huge deal. Why? Because a full 75% of cases of something called acute compartment syndrome, which is a really serious limb-threatening problem we're going to talk about, start with this exact kind of fracture. So for our patient and for the paramedics just arriving, the stakes are already incredibly high. All right, our patient is at the hospital. They're in a ton of pain, they're probably scared, and nothing makes sense. But here's something a lot of people just don't know. In this very moment, you are protected by a really powerful federal law that guarantees your right to get care. It's called EMTLA. It's a mouthful, I know, but it's basically the Anti-Patient Dumping Act. And the main idea is actually pretty simple. If a hospital takes Medicare payments, it has a legal duty to check out and treat anyone who shows up at their door with a possible emergency, period. So here's the bottom line, and this is so important. Under EMTLA, care comes first. The hospital has to give you a medical screening exam to figure out what's wrong. And get this, they cannot ask for your insurance card or how you're going to pay before they do that screening. If they do find an emergency, they have to stabilize you. And if they're not equipped to handle your specific problem, they are legally required to find a hospital that is and get you there safely. Now, let's just flip the script for a second and look at the provider's side of this. For the doctors, the nurses, the hospital staff, this quote is their Bible. Every single thing they do to follow EMTALA, the screening, the diagnosis, the treatment, the decision to transfer, it all has to be documented perfectly. This isn't just about good medicine, it's a legal shield that proves they did their job correctly. Okay, let's get back to our patient. They're in the ER, they're getting that screening exam we talked about, and as the medical team starts to figure out just how bad that leg injury is, they're about to find something that requires immediate surgery. The diagnosis? Acute compartment syndrome. This is exactly the kind of complication that first responders are trained to look for. They might feel a limb that's super tense, almost hard like wood, or hear patients say the pain is just off the charts bad, way worse than the injury looks. What's happening is the pressure inside the muscle is building so high that it's literally choking off its own blood supply. And this just shows you why it's such a desperate race against time. It's a vicious cycle. The swelling causes pressure, right? That pressure squeezes the veins so blood can't get out. Well, that makes the pressure even worse until it finally starts blocking the arteries that bring fresh, oxygenated blood in. And at that point, the tissue just starts to die. The only way to stop it is an immediate surgery called a fasciotomy to slice it open and relieve all that pressure. So our patient is now getting treatment. They're in a hospital room, probably staying overnight. That means they're an inpatient, right? Well, maybe not. And the answer to this question can have massive, and I mean massive, financial consequences. Okay, let's break this down because it's a little confusing but so important. To be an inpatient, a doctor has to write a specific order to formally admit you. That's usually covered by Medicare Part A, where you pay one deductible. But you could be in the very same room, getting the very same care, and be classified under observation status. That's considered an outpatient service, covered by Part B, and you can get hit with copays for every little thing. And here's the real kicker. Observation days don't count toward the 3-day hospital stay you need for Medicare to cover a skilled nursing facility. So the bottom line is this single decision, which is based on the doctor's judgment and some pretty complex Medicare rules, can literally change your final bill by thousands and thousands of dollars. It's one of the most confusing and financially dangerous parts of a hospital stay. All right, our patient's surgery was a success. They're starting to recover. But now comes the next hurdle. The medical bills start showing up in the mail. And with them comes the potential for a really nasty surprise. This is what's known as balance billing, or what most of us just call a surprise bill. And it happens all the time in emergencies. You're smart, you go to a hospital that's in your insurance network. But the anesthesiologist who put you under, or the radiologist who read your x-ray, turns out they weren't in your network. Next thing you know, you get a bill for a shocking amount, the balance your insurance refused to pay. But here is the really good news. A new federal law has actually put a stop to a lot of these horrible practices. It's called the No Surprises Act, and believe me, it is a total game changer when it comes to protecting patients from financial ruin. For emergencies, this law has your back. It completely bans those surprise bills from out-of-network doctors at in-network hospitals for things like anesthesia or lab work. Your part of the bill is now limited to what you would have normally paid if everyone was in network, so your usual copay or deductible. It shields you from those absolutely terrifying out-of-the-blue bills. Okay, we've covered a ton of ground here, right? From the 911 call all the way to that final bill. So let's wrap this up and pull together the most critical things to remember, both for patients and for the professionals who take care of us. For patients, it really boils down to three things. Number one, know your rights. You have a right to be checked out and stabilized no matter what your bank account looks like. Number two, you have to ask the question, am I being admitted as an inpatient or am I under observation? It makes a huge difference. And number three, understand that the No Surprises Act is now your best defense against a financial catastrophe. And for all you first responders and hospital staff listening, the takeaways are just as crucial. Remember, ETAMA kicks in the second that patient is on hospital property. That medical screening exam, it's not a one-and-done checklist. It's a continuous evaluation. Clinically, spotting those time-sensitive problems early is everything. And from a legal standpoint, if you didn't write it down, it never happened. So we'll end on this thought. We've laid out all the rules, the rights, the laws that are supposed to guide you through a medical crisis. But knowing your rights is one thing. Actually trying to navigate this incredibly complex and stressful system is something else entirely. The real question is, how can we make this journey clearer, safer, and just plain better for every single person who has to go through it?